So the criteria for AVNRT is going to be a regular rhythm, maybe slightly irregular at onset, especially if it is cued by a PAC. The rate's between 150 to 250. P waves can be buried or they can be pseudo-S or pseudo-R complexes. Now, one thing to consider, treatment-wise, we're going to figure that any SVT that's narrow and rapid and regular will be AVNRT until proven otherwise. So the rules for AVNRT, the rate's going to be anywhere between 150 to 250 ventricularly. It's going to be a regular rhythm. The P wave most likely is going to be inverted or buried. If it's inverted, it's usually going to be post QRS. The P to QRS ratio is a 1-to-1. There won't be a PR interval. The QRS width should be normal, if not even a little more narrow, with no grouping and no drop beats. Things that can cause it is caused because of the presence of a dual pathway approaching the AV junction, and it's normally found in patients without other structural heart disease. So let's look at a couple of examples. My rate is 180. My rhythm is regular. No P wave, no PRI, and my QRS is normal at 0.08 seconds. So it is a narrow ventricular complex without a P wave at a rate of 180. It's a AVNRT. What if you called this a supraventricular tachycardia? You wouldn't be wrong. The treatment's still going to be the same initially. This is a really rapid rhythm at a rate of 200. It is regular. The QRS complexes are narrow and there's no discernible P waves. There is, however, a small S wave noted at the end of the QRS complex, which is talking about right there, that possibly could be a pseudo S wave. The SD segment is depressed, as it's common in rapid tachycardias, and this could be due to relative endocardial ischemia due to the rapid rate, but the cause is usually unclear. No P wave, no PRI, QRS is 0.06 seconds, AVNRT. So this ECG was obtained from the same patient that we just looked at, so we already know that the underlying rhythm's AVNRT, but they've got this in V1 so that they can look for the pseudo R wave. At the end of the QS, which is indicated right here, the blue arrow, and so it does look like a pseudo R wave. Regardless, the treatment's still going to be the same. My rate is around 190 to 200. Rhythm is regular. No P wave. No PRI. QRS is 0.08 seconds. AVNRT. My rate is 190 to 200. This is again this is the same strip from the previous that we just did, but again, we got it in V1 to check to see if there's a pseudo R, and there is a pseudo R wave that's a little more present, which indicates a post QRS P wave. AVNRT. Rate is 200. It's regular. No P, no PRI. QRS is narrow at 0.12 seconds. Rate is 190. It's regular. No P, no PRI. QRS is 0.10 seconds. Narrow complex AVNRT. Rate is 190. Rhythm's regular. No P wave, no PRI. QRS is 0.06 seconds. And lastly, rate is 210. It's regular. No P, no PRI. QRS is 0.06 seconds. So this is a rapid narrow complex tachycardia. The QRS complex is pretty clearly defined. ST segments are depressed and have a scooped out appearance. This pattern of ST depression may be due to the tachycardia, ischemia, or digitalis effect. Clinical correlation and comparison to an old ECG are critical in arriving at the field diagnosis. Remember, however, treat the tachycardia first, then worry about the final diagnosis. AVNRT should be the first thing on your differential diagnosis list.